This is your lecture on adrenergic blocking drugs. Adrenergic blockers are going to bind to adrenergic receptors to either inhibit or block stimulation of the sympathetic nervous system. So this is now the opposite effect of our adrenergics. They're also going to be known as adrenergic antagonists, sympatholytics, alpha blockers, beta blockers, or we can have a combination of alpha and beta blockers. They are classified by the type of adrenergic receptor that they block. Starting with our alpha blockers, they're going to cause both arterial and venous dilation. This is then going to reduce peripheral vascular resistance, causing vasodilation, which will then in turn decrease blood pressure. So we use this to manage hypertension. They also can work on the receptors of the prostate and bladder to decrease resistance to either urinary outflow or if there's an obstruction, and then relieve the effects of something called BPH, which is benign prostatic hyperplasia. We can use our alpha blockers to either control or prevent hypertension, especially in those patients that have a pheochromocytoma. And that's a tumor that sits on the adrenal glands that secrete hormones that put the sympathetic nervous system into overdrive. We can also use this for Raynaud's phenomenon. And with Raynaud's, what happens is there's vasospasms that occur in arteries that supply blood, and it's mostly to your fingers and your toes, but it can also be to your earlobes or your nose. And it can be very problematic because if you go with too much vasoconstriction to the extremities, you can actually lose digits. In regard to adverse effects, the most important thing to note is first dose phenomenon. So there's a really severe and sudden drop in the blood pressure after the first dose. This still can occur with any dose where you have orthostatic hypotension. So it's really important that you educate your patient to not only assess their blood pressure before, but know what to watch for should their blood pressure drop. If there is any overdose, it's symptomatic care. So if the patient becomes hypotensive, we might give them fluids to help increase their circulating volume or give them something called albumin. But if it's low enough, we may need to start vasopressors, and we would obviously stop the medication. We do need to also be very mindful of giving an alpha blocker with highly protein-bound drugs because those highly protein-bound drugs are going to compete for binding sites. So the drug that has more protein is going to bind, and the other one is going to be a free drug floating around causing toxicity. Our prototype drug for our alpha blocker is tamsulosin or Flomax. So tamsulosin is very commonly used in the acute care setting, and you'll know when you see that medication ordered, it's typically going to be for your patient that has benign prostatic hypertrophy to help with urination, although it can also be used in female patients that have kidney stones or any sort of urinary retention. We want to make sure that this isn't used with concurrent erectile dysfunction drugs such as sildenafil, because those drugs cause vasodilation and alpha blockers cause vasodilation, so that can be extremely problematic. Our next category are our beta blockers. Beta blockers are going to block stimulation of the beta receptors in the sympathetic nervous system through competition with norepinephrine and epinephrine. They can be selective or non-selective. What do we think that means when we say something can be either selective or non-selective? Well, that means that we're either selectively blocking beta or we are non-selectively blocking beta. So non-selectively blocking beta meaning we're blocking both beta 1 and beta 2. So why could that potentially be problematic? Well, if we stimulate our beta receptors, beta 2 is going to cause bronchodilation. Now, if we give a beta blocker and beta 2 is stimulated, it's now going to cause bronchoconstriction. That could be extremely problematic for our patients that have any sort of respiratory disorder like COPD or asthma. So we could potentially exacerbate that by giving a non-selective beta blocker. Uses for beta blockers are going to be angina, so that's chest pain. It's going to decrease the demand for myocardial oxygen. It's also cardioprotective in our patients that have had an MI and can also be very effective for our patients with heart failure because it's going to slow the rate down but improve the force of contraction. We can also use this as an antidysrhythmic and off-label for migraine headaches, and also very commonly utilized for antihypertension. It is really important to note, specifically with our beta blockers, not only are we going to see a decrease in our blood pressure, but we are also going to see a decrease in our heart rate. So that means we need to assess both the heart rate and the blood pressure before we administer the drug. Very important. You'll also notice that the names for your beta blockers end in olol. So if you ever see a medication ending in olol or alol, that is a beta blocker. Metoprolol, labetalol, propanolol. So if you ever are asked this on a quiz about the drug name and you see olol, you'll know it's a beta blocker. Most important things to watch for: hypotension and bradycardia, because those are what you are expecting to see. So always make sure, again, to reinforce how important this is, that you double check that. As far as our adverse effects, our non-selective beta blockers can block that normal response to hypoglycemia. So for example, if you know your blood sugar is low because your heart rate starts to speed up, you have tremors, maybe you're a little nervous, and you take a beta blocker, those symptoms are going to go away because of the beta blocking. So then those indicators that you had to tell you that your blood sugar was low are gone. So it's very important for our diabetics to watch this very closely. If there's any sort of overdose or toxicity, we can give atropine if the patient's bradycardic, and if there is severe hypotension, we can give vasopressors. And here's a fun fact: there actually is a medication that we can use if there is an overdose of our beta blockers, and that is glucagon. We can give high-dose glucagon, and that's our first-line agent. So something just helpful to know. Our prototype drug is atenolol, also known as tenormin. It is a cardioselective beta blocker that we use for hypertension and angina. It can also be used to prevent future heart attacks for patients that have previously had one. We can also use this for thyrotoxicosis, so those are patients that have very high levels of thyroid hormone in their system. Our next medication, carvedilol or Coreg, this is a non-selective beta blocker and an alpha-1 blocker, a calcium channel blocker, and it also can be combined with other medications for patients that are suffering from heart failure. We can also use this for hypertension and angina. It's going to slow the progression of heart failure to decrease the frequency of patients needing to be hospitalized if they have class 2 or 3 heart failure. Our next drug, labetalol or normidine, this blocks both alpha and beta adrenergic receptors, and we utilize this very commonly in the ICU for hypertension or hypertensive emergencies. It's very potent, and it's very important that we watch our blood pressure closely because it will drop it pretty quickly. Our next drug, metoprolol or Lopressor, very commonly used medication. You'll see this in the community setting very frequently. This is our most commonly used beta blocker. And if we do give this intravenous, the patient must be on a cardiac monitor, and we need to assess very closely. You'll see the blood pressure and the heart rate trend down pretty quickly, so we also want to make sure we don't give it too fast. There are 2 oral forms that you should always make sure you clarify the order to make sure it's the correct one. We have metoprolol succinate, which is extended release, ordered once daily, and then metoprolol tartrate, which is an immediate release, ordered twice daily. Our next drug, propanolol or indolol, is our prototypical non-selective beta-1 and beta-2 blocker. We can use this for tachydysrhythmias, subaortic stenosis, migraines, and even tremors. Our next drug, sotalol or beta pace. This is a non-selective beta blocker that has very potent antidysrhythmic properties. So this is also great for patients with atrial fibrillation. I've added a slide on nursing implications and patient education because I feel this is very important, especially with this category of medications where we are now putting the patient at risk for hypotension and fall risk. When we're giving adrenergic agonists, those patients are going to be in the hospital. They're going to be under very close watch. However, with our adrenergic and beta blockers, these patients are going to be at home. So it's really important that we provide extensive education to make sure that they're being safe when they're taking their meds. So we need to be very mindful of the risk of hypotension. They should always be checking their blood pressure before their dose. Even recommended to keep a log so that they know before their dose what their blood pressure trends have been. We also want to make sure that they know, do not abruptly stop taking this. Patients, what I don't think people realize is if somebody's normally got a blood pressure of, let's say, 160 over 110, that's a pretty high blood pressure and they're used to a lot of perfusion. If we now give a medication, their blood pressure now becomes, let's say, 95 over 40, they have a lot less perfusion than what they're used to. So they might be more lethargic, tired. It's going to be very challenging because it's a very big difference. So we need to educate them what to expect and that they might feel not so great until they adjust to the medication. So give it some time, don't stop taking it. If you're feeling symptomatic, call your healthcare provider and have a conversation about it. They should also make sure that they're changing positions slowly, especially going from laying to sitting or sitting to standing. They have a really high risk of syncope, which is basically passing out, and that puts them at a really high risk for injury, whether it's they could get a hemorrhagic stroke if they hit their head, any sorts of cuts, abrasions. It could be very problematic. So we really need to make sure that they are being safe.